A very good afternoon, everyone. Thank you to the organizers, especially Dr. Nandini, for inviting me here for this lecture. It's a difficult task post lunch to speak on molecular biology of prostate cancer and molecular testing. And as you can see, I'm a chairless speaker here today. We had a good discussion in the previous session with Dr. Akhil, Dr. Samir, and Senthil sir here to who discussed about HRR and all, and I'll be touching upon them briefly. Some ethical disclaimers: there is no breach of confidentiality of patient in this presentation, and I have to admit that I'm not a molecular biologist. I'm just a clinical pathologist doing some clinically oriented pathology and trying to understand the nuances of what is important in the clinical practice. So this is our 12 slides, which we see every day, 12 core biopsies of the prostate. And the important things we all know is the Gleason scoring, which in day-to-day practice helps in predicting a lot of things, especially surgical parameters like extraprostatic extension, seminal vesicle invasion, nodal mets. And obviously the prognostic importance also comes from metastasis finigram. And it has been proven beyond doubt that the grade grouping system is prognostically important. And these are the different Kaplan-Meier curves which have been plotted for all the grade groups. So what are the unmet or partly met or the gaps in prostate cancer care? We know that active surveillance, which of the Gleason 6 may turn out as villains, is a big question. I'll not go into the detail because my talk is on advanced prostate cancer. But we do have some molecular markers in that unmet kind of where we decipher, oncotype, DX, and all those tests, even in that setting, although not 100% concordant with what happens to the patient, but they can predict how the patients would behave before when put on active surveillance. The very unmet need is which of the tumors are going to respond to therapy. We have a gamut of markers and gamut of things, but are there a set of markers which really can predict therapy? I think that's a very, very big gap in overall in our understanding of and management of disease. So in advanced prostate cancer, can something help us in predict the course and delivery of personalized care? So these are the most important questions, and this needs an in-depth understanding of the molecular genomics and genetics of prostate cancer. If you look at the natural history of prostate cancer patient, these are the 4 broad categories. You have a high-risk localized cancer, which may be locally advanced, and then you may have locally advanced, and then you have a metastatic hormone-sensitive prostate cancer and the castrate-resistant. And there are different kind of treatment options for these across the board when we look at these patients. The outcome remains pretty poor for patients with advanced prostate cancer. Stage 4 with metastasis, the 5-year survival is close to 30%, although it is improving day by day with a lot of different kind of therapies available. Now, if you look at the molecular genomic events in prostate cancer progression, one of the early events which you see here, I can't point out. Sorry. So I can do that here. So the primary genetic fusion is the TMPRS or the ETS gene fusions. We did study in TMH also on 100 cancer patients of prostate. We did study these mutations, and we found that around 30% to 50% of the patients would have this ETS mutation, which is a very primary event. So once you have a very primary event in any cancer, that's generally not a very targetable, because it is across the board, across all kinds of cancers, all kinds of aggressive and non-aggressive, this TMPRSS fusions might be seen. As the disease progresses, the AR mutations, the AR amplifications, the AR sensitivity of these tumors becomes less, and that's how they escape the androgen and become androgen independent. The worst, of course, we discussed in the panel also, is the neuroendocrine and the aggressive variant of the prostate cancer, which have got different importance. Before we delve into details of what are the molecules exactly we should look for treatment, just a brief overview of what personalized medicine means. We are looking at prediction, diagnosis, prognosis, and therapy based on these molecular markers. That's the target. And in the current era, if you ask which tests you should be doing for molecular, I think the one-stop shop is NGS, because it covers a lot of different things. So there are labs which are doing FISH testing, the labs which are doing IHC, but if you want to have a comprehensive answer of what are the genomic events happening in the given patient, advanced prostate cancer patient, I think the test to go is the next generation sequencing. It is effective for all size scales, small translocations, RNA translocations, and fusions, and all those can be tested. And you have different platforms to test these tests. I'll not go into the details of the testing. And this is briefly just to say how you break down the DNA, you clonally amplify them, and then you sequence them, and you give different kinds of reports which you receive from the molecular lab regarding these tests. And you will find in your reports the sequencing variants. The most important are the first two categories, that's the tier 1 and tier 2 are the pathogenic and the likely or the pathogenic tier 1 and tier 2 mutations, which are actionable. So these are the mutations which have got drugs against them. There are studies, there are trials against them, and they are the tier 1 and tier 2 reports which you get on NGS, which are targetable. So coming to the main theme, preventable genomic events in advanced prostate cancer. I think we discussed in the panel that the HRR pathway and the DNA damage response genes, that is the BRCA and the MMR, are the most commonly studied. The BRCA and it's all HRR pathway genes are the most commonly studied genes. We have something like the PIK3CA and the PTEN axis, which is also being understood slowly in prostate cancer advanced cases. So if you look at the germline mutations in prostate cancer, it's 1 in 10 mutations which you see in these tumors. 11.8 is the figure with metastatic prostate cancer, and 4.6 in with localized disease. So the most important utility of understanding the molecular pathways and the molecules to target these when they become metastatic and are not amenable to any further kind of treatments. If you look at the pie chart here, the BRCA2 is far more commoner than BRCA1, and like Senthil sir pointed out, it is the ATM and check are even more commoner than BRCA1 in these settings. So these are the DNA damage response genes, which are basically the BRCA genes, as well as there are other ones, there's the MMR genes, which I'll be alluding to later on. So this is the basic thing: the single strand repair path, the mismatch repair, the NER pathway, the base excision, and the double stranded DNA repair pathway is the BRCA1 and the NHEJ pathways. So what happens to this? I'll just briefly, this cartoon tells you that in a normal cell where both BRCA and PARP are active, they can repair both single and double stranded breaks. In a BRCA mutated tumors, the PARP, if it is active, it will take over and repair single strand, each strand, and then they can be joined together and the cells continue to be there. If you start using PARP inhibitors in a BRCA mutated patients, you can see that both BRCA and PARP get blocked, and that's how the cell enters into a pathway where it's a lethal kind of a damage to the cell. So that's the importance and the value and the understanding of molecular pathogenesis, that you use these inhibitor therapies in this. It has been proven beyond doubt that BRCA1/2 confers more aggressive phenotype. These are the patients who have high Gleason score. They have they metastasize early. They present at a later stage. They're less amenable to common treatments. So as a pathologist, when I see under the microscope, these are these. So intraductal prostate cancer, cribriform pattern. These are the ones you would put in your report. Probably they should be tested for BRCA mutations. And these are NCCN guidelines definitely states that intraductal prostate cancer, IDCP and cribriform morphologies should be tested. But then when it comes to testing, it's a question of germline versus somatic. And there are a whole lot of guidelines: whom should you test, when should you test, and what are the features. And we'll come to that in a while. So this was a trial. Some of these some of these slides I've borrowed from Dr. Amit Joshi, and that's why they are all medical oncology slides. So you can clearly see that presence of genomic defects and DNA repair genes can really help you in marketing your therapy in these patients. Another important one is the CDK12 alteration, also part of the HRR pathway, 12 gene. And they are very amenable to immunotherapy agents like pembrolizumab and nivolumab. The problem is these are very, very minuscule. So if you end up doing 100 cases, you may find it in 1 or 2 patients, maybe in this metastatic setting. The point is, unless until we start doing these tests, we are not going to learn how they are going to behave and how they are going to present to us. So they are candidates, and this is from one of our own patients and from a molecular tumor board who did have this CDK12 mutation. And the standard therapy in these patients would include a PARP inhibition, or more recently, the data has come that which says that these are more amenable to immunotherapy agents. And that's the importance of testing these patients with molecular. A word about genetic screening. I'm sure you get in your practice patients who would come, who would say, should I test my son? Should I test my brother? those questions are going to come, and more patients are going to ask us about this. So I do gynecology, gynec path also. So in at least in ovarian cancer, every third patient has this HRD mutation, and many of they have a families of hereditary breast and ovarian cancer, and it's extremely important to understand the value of genetic screening and testing in these patients. So these are some theoretical slides. Uh, um, that germline DNA mutation BRCA1 and 2, like I said, 11.8% of men with metastatic prostate cancer may have these mutations. They are generally more aggressive, and that's what we need to know. There are several guidelines which can tell you when to test, and this is just a table to show when to test the patient if he has family history, if there is a history of breast cancer, ovarian cancer in the family. Those are the patients who become candidates whom you should be testing BRCA1, BRCA2. Again, there are several other things like more than one first degree relative, more than two first and second degree relative. So these are all available. I'm not going to the details, but the question is, whenever you encounter an advanced prostate cancer patient de novo, and those are the right patients where you would probably take a family history, where the patient himself might want you to do the testing in their whole family, and that's an important part of what we are going into in the current era. So these are all guidelines. You have the Philadelphia Prostate Cancer Consensus Conference, you have the AUA guidelines, you have the EU. Many of the guidelines now say all metastatic prostate cancer patients should undergo BRCA and HRR kind of testing. I don't know, Dr. Senthil, you would agree with that? All metastatic, I still don't think in India we are testing all metastatic prostate cancers for HRR. But many of the patients who put forth this question of genetics and all would be candidates where we should do the opportunistic kind of testing in these patients. So the question is germline versus somatic. I think this question cannot be answered very simply. Should you test the main tumor? Should you test a germline? But as we'll know that many patients would have germline also. So we do germline and we test the family of these patients also. We have a hereditary clinic proper in which they are counseled, and then that's how it is taken forward. I came across this very interesting study from a Dutch multidisciplinary consensus meeting on how this. So this is about 39 experts who sat together and had their Delphi method of questionnaire, and they have said that in a hormone sensitive metastatic setting, they still would not change their management. 76% of the respondents or the experts agreed that even a high volume metastatic hormone sensitive, even if they turn out to be BRCA2, would not be candidates for targeted therapy in this setting. Vis-a-vis, if you compare in a CRPC setting, 72% respondents or the participants said that after one line of NHA and docetaxel, they would consider giving a PARP inhibitor in these patients. So even the real world scenario and the real world data and the understanding amongst the oncologists is different across the board. And the important question for the oncologist is always, should we take the previous old biopsy and do the testing in that? I think as the disease progresses, there is no point in doing testing on a biopsy which was done 5 years back when he was diagnosed with prostate cancer. It is always good to do a fresh biopsy from a metastatic site or a fresh biopsy from a more accessible site, because that's going to give you the whole range of what the genetic mutations currently are. We do get sometimes requests that patient is metastatic now, can we have the old biopsy? We want to do a genetic test. I don't think that's the ideal way to do testing on those patients sometimes, because the tissue sometimes is very, very depleted, and it is not very good quality if you keep old blocks. Coming to MMR gene, not too many of them. We do get requests for MMR testing in metastatic prostate cancer. I remember only one case as of yet, which was MSH6 mutated, which I've come across on IHC at least. So it's not a common occurrence. The germline MMR mutations are only to the tune of 1%. But in a somatic kind of testing, you might find 4-5% of tumors having MMR deficiency. I'll not go into the details of these, but the 4 main genes which are tested are the MSH2, MSH6, MLH1, and PMS2. The good part about MMR testing in prostate, it can be easily done on immunohistochemistry. So the routine labs which have immunohistochemistry can do this test and tell you whether there is a chance of this being a MMR or MSI high tumor in this setting. So these are again some values that only 2.7% of metastatic CRPC patients are MSI high, and they're very, very few numbers. Even if you look at studies and literature, you will not find too many studies on MMR mutations in prostate cancer. But if you find they are candidates for immunotherapy, so the question is, even if you are two patients, for that patient, the chances of using immunotherapy in these patients is would be nice. And there is some problem with this slide, I think. Sorry. Coming to the PDL1 testing and immune checkpoint inhibitor, again, PDL1 is not very commonly expressed by prostate. We have to understand the basic pathology, and what we see under the slide as a pathologist is that prostate cancer is not an immune regulated tumor. You don't have a lot of immune cells. When you look at the slide of prostate cancer, if I see an area of inflammation, I don't look very carefully, because prostate cancer per se does not elicit a lot of inflammation. Unlike, say, breast cancer or lung cancer, which elicits a lot of inflammatory tissue, prostate cancer is largely not an immune regulated tumor, and that's why the response to PD-L1 therapy, PD-1 therapy is not great in prostate cancer. So these are some literature which I found. A very minuscule kind of response in these patients is seen in these. A very latest and new findings which have come up in the last 4-5 years is the PIK3CA PTEN axis in prostate cancer. It is now understood that when the patient becomes castrate resistant, about 40% can have PTEN mutations in them, and these are targetable. You have drugs like capacitive to target these PTEN mutated patients. Mind you, we had a discussion on PTEN IHC. PTEN IHC is not a very easy stain to do. We have to look for PTEN loss in the tumor, and doing a IHC where you have to look for loss becomes difficult. PTEN IHC is not a great IHC to do. So you may have to delve into details and do a proper molecular profiling in these tumors to pick up these PTEN mutations. So this is again a graph to show that giving ipatasertib in these patients with PTEN mutations marginally improves their PFS in this trial. So this is based on IHC, that PTEN loss associated with poor outcomes in patients who treated with abiraterone. So but the point of talking all these molecules is that there is subtle and definite improvement of these patients if you are able to get these reports. The problem with molecular testing in current era is the issue of standardization. You may get a lab which says this, they may get a lab which may say another thing. The problem in our molecular tumor boards is sometimes the patient, when he gets tested from 2-3 different labs, you may have different gene mutations which come up, and then the question and problem comes. The charges are very expensive. Only few patients are able to afford these kind of testing. Another thing in prostate cancer is the ARV7. This is an old article from 2014. Everybody has read this, of the ARV7 variant, where giving enzalutamide and abiraterone may not be very effective. So it might be a good idea to test the patients for ARV7 variant in the androgen receptor. And if the patient turns out positive, the outcomes to treatment with enzalutamide and abiraterone are not great in these patients. The problem is, do you test it in the early setting? But the answer is no, because at presentation, the presence of ARV7 variant is not, it's only when the disease progresses, advances, that's when these variants pick up and the variant can resurface and you can find them in the day-to-day practice. A very important aspect of prostate cancer, which all of us are going to see more and more, we had discussion in the panel, is the neuroendocrine cancers. So neuroendocrine, small cell, large cell prostate cancer, more and more as you use enzalutamide, more and more as you use this novel androgen receptor pathway targeting drugs, you will find that you will come across these. And we had a discussion that these tumors have visceral mets, they have lytic bone mets, the PSA is low, and you see that nodal mets are more in these tumors. So that's how they present when they are on. So they are androgen independent. As you can see, the androgen independence of prostate cancer comes from amplified androgen receptors, mutated androgen receptors, and developing the neuroendocrine phenotype. So this is what from MSKCC, Dr. Himisha Beltran has done a lot of studies on this aggressive prostate cancer variant. And there is a phase when they are neither androgen expressing tumors, nor do they express a neuroendocrine phenotype. And that's when, I think Samir, you are talking about that. There is a time when they are not, they will not be androgen receptor positive. They will neither be positive for neuroendocrine. And we have seen a couple of cases like that actually. But they are very aggressive. You can make out on histology itself, you can make their very strong. So this is how a small cell carcinoma looks under the microscope. A very blue looking tumor, high NC ratio, a lot of crushing artifacts. That's how we pick up the diagnosis of small cell carcinoma in these patients. The molecule which is important for this transformation is the EZH2 pathway. Yeah, that's last 2 slides. And this is what pushes the prostate to develop androgen independence and become a neuroendocrine phenotype. So testing for EZH2 might tell you early in life that early in the course of the disease that this patient might develop a neuroendocrine phenotype. A very important point, crosstalk between clinician pathologists is which block to select, tumor tissue content, and is it ideal to take fresh biopsy? To circumvent this, we have the newer technique, which is the circulating tumor DNA. I think those are important because from the blood, all the tumor cells of all the metastatic sites are there, and all this DNA can be gathered from the peripheral blood. So, doing a circulating tumor DNA from the peripheral blood would be more informative and give you the whole range of mutations which the patient has in a metastatic setting. You cannot start targeting each and every biopsy, every site. That's very difficult to do that. So I think I'll conclude this. This is the snapshot of genetic events. You can see there is a whole list of genes and whole list of therapeutic options. This list is going to increase. The therapeutic options are going to increase. The question which we always ask is whom to test, when to test, expenses, and the financial toxicity that the patient undergoes with these kind of a lot of testing in this day-to-day setting. I think I'll just summarize this is that NGS-based testing requires good tissue optimization, something which we all forget. In a country like India, I think that's a major challenge when you are testing tissue, molecular testing. The tissue is the main issue which you find problems. I think DDR gene mutations are seen in about 20-25% advanced prostate cancers. And that is the mainstay when we talk of molecular testing in prostate cancer. MMR mutations are very, very minuscule, but if found in a patient can be targeted to ICI therapy. And then in the future, what we are going to see more and more as the EZH2 inhibitors, which are going to be tested in prostate cancer pathways. I think I have a big thanks to all my friends, especially to Dr. Amit Joshi. Most of the slides have been borrowed from him because this is a medical oncology session, and I think I had to borrow some of the slides from him. Thank you so much, please. We're happy to take some questions. Yes, Amish. Mm-hmm. Tissue is okay. See, the point is blood is easily accessible and tissue, our problem. So we did a study now, if Nandini is around. We did the study on many old prostate biopsy. Recently, we have done BRCA testing on them, sending them to Bangalore for testing. The old blocks, which are 5-year-old, really don't give you good DNA. So in those cases, better to test. So my point is, if a patient is a known case since 5 years, taking out his old tissue and doing some testing, and that may not yield you the results. It's always good to take a fresh tissue.
So means both are equal, either way.
Yeah. For germline, we have BRCA.
Yes. Sir, just a question. If we do HRD testing, we will require more tissue. In ovary, it is easy because we get surgical specimen. In metastatic prostate, we get small chips of biopsy. So if we want to do HRD, can we do in the same sample?
Same sample as the?
Means in the biopsy sample, or we require more tissue when you do?
We can do in biopsy sample. Yeah. Yeah, Vinod.
Many times we get BRCA2 VUS and reports like this. So that only means that this specific variant is not included in the CliniVar or Embrace, whichever the database.
You said VUS.
Yeah. We don't know what the significance of that because it's not reported anywhere.
Yes.
So in a therapeutic point of view, if you have a VUS and we cannot confirm, for example, BRCA2 VUS, do you think that doing an HRD will actually give an answer whether, at least from therapeutic point of view, it will be?
I really don't think so. In the current scenario and current information literature, I don't think so. Doing a full HRD with loss of heterozygotes, chromosomal aberrations, and telomeric, all this is going to yield, at least in prostate cancer. So because ovarian cancer, by and large, has got a lot of genetic aberrations, and it's a very aggressive tumor compared to prostate, what we have actually, to begin with.
Thanks.
Thank you. Thank you so much.